Namaste and greetings. I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान नई दिल्ली, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today we are gathered here for Day 2 of Healthcare and Gender Equity, Emerging Dimensions, Policies, Impact and Way Forward, an online international Monsoon school program, a 4-day immersive online hands-on certificate training course. This training program is organized by IMPRI Gender Impact Studies Center, GISC. The chair for this program is Professor Vibhuti Patel, visiting distinguished professor, IMPRI. This program has an excellent panel of experts who will be sharing their expertise for 4-day online certification course. The distinguished panel of experts includes Professor Vibhuti Patel, Professor Poonam Naik, Professor Mala Ramanathan, Dr. Aksa Sheikh, Professor Sanghamitra Acharya, Dr. Amar Jasani, Ms. Sangeeta Rege, Dr. Padma Bhatte Deosthali, and Professor Uma Kulkarni. The conveners for this course are Dr. Veena Vaswani, Director, Center for Ethics, Professor, Department of Forensic Medicine and Toxicology, Yenepoya, deemed to be University, Mangalore, Farhad Yenepoya, Pro-Chancellor Yenepoya, deemed to be University, Mangalore, and Dr. Simi Mehta, CEO and Editorial Director, IMPRI. The participants would learn from globally and nationally renowned thematic experts and practitioners. They will gain first-hand insights and networking opportunities. They'll get course outline and reading list from the experts for learning, get access to session videos for 15 days, receive a certificate of completion, and have the opportunity to publish their essays on the IMPRI Insights blog. I welcome you all to this enlightening deliberation and thank you for putting your time, energy, and efforts into truly understanding the healthcare and gender dynamics and their intersection in the current scenario. Before we start today's session, I would like to announce the housekeeping rules. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise and refrain from making general comments in the question to save time. Our session for Day 2 will cover topics of pandemics, epidemics, and gendered healthcare system by Professor Sanghamitra Acharya and visibility of gender in health statistics and health indicators by Dr. Mala Ramanathan. Now, without any further ado, I would like Professor Vibhuti Patel to take over and begin the session for Day 2. Over to you, ma'am.
Good evening, friends. First of all, I would like to express my heartfelt thanks to Professor Farhad Yenepoya, Pro-Chancellor of Yenepoya deemed to be University, Dr. Arjun Kumar, Dr. Simi Mehta, Dr. Veena Vaswani, anchor who has initiated this course, Vidita, Fiza Mahajan, and Ms. Vaishali Singh for putting this course together. Welcome, Professor Sanghamitra Acharya and Professor Mala Ramanathan. We would first of all have a recap of what transpired yesterday. Yesterday's session began with a macro perspective on health policies, and Dr. Poonam Naik, who spoke on the gender implications of health policies, started with the data from NFHS 5, and she gave the demographic profile, the gender and demography, and the social problems that India encounters in terms of child marriage, child mothers, anemia, malnutrition, vulnerability of women in pregnancy, total unmet needs in reproductive and child health, and the overall health of women, the concept of equity versus equality, which provides the rationale for affirmative action by the state, and the WHO guidelines are also based on this philosophy. She also took up the issues of son preference and how women have to undergo repeated pregnancy, the health risks, and also the operation of some health laws like a PCPNDT Act. And the main thrust of her argument was that we need to focus the health, we need to transcend the biomedical obsession and also understand the institutional factors and the social positioning of women and how the gender norms and culture, they also impact, and accordingly come up with the health intervention policy. She also gave a personal experience of various schemes and programs. The most interesting part of the session was an extremely interactive and lively session. We had many questions regarding anemia, whole recent debate on the removal of anemia indicators from NFHS survey. Then the sensitive indicators, how can we create the sensitive indicators for assessing health policies? What should be done to strengthen the Anganwadis to combat malnutrition, which has now emerged as a very important factor, important challenge as per the NFHS 5. The question of national mental health policy, in what way is it effective, what is happening at the ground level, the question of total fertility rate, which has gone down in so many states, 20 states, it is below stabilization, and still why are we continuing with the vertically imposed population policy? What is the role of multinational corporations and the corporate sector? Can the private sector contribute to strengthen the healthcare system? Then the question of some of the important policies that have come in terms of question of postpartum depression and the mother care clinic, the whole new concept that has emerged, and also the question of various scheme workers, why are they treated as volunteers and not as workers? The second presentation by Dr. Ms. Sangeeta Rege was equally important and lively, and where she talked about the gender and human rights with a special focus on various on also how can we change the attitude of the medical colleges and gender in medical education. She also gave a very interesting exercise with that also energized the participant, the FACES exercise it is called. And she also said that gender is treated as a software because it can change, while the patriarchy is a hardware, which is very difficult. You try to fight against the one form of patriarchy, and then suddenly like octopus, other tentacles of patriarchy, they pose more crisis for women. Then the question of transgender women, their problems, and how the competition of cisgender women and the transgender women in the sporting events or racing team, where or in sports, they faced some of the biases, and their awards were, and the battles that were taken back. What is the level of why women have a disproportionate burden that the gender minorities are facing? What are the organizations at a grassroots level working for providing support structure to the gender minorities? The question of forcible hysterectomy, which is imposed by the sugarcane employers on women sugarcane workers. The question of women to maintain the production target, how women in the garment industries and so many export processing industries are forced to postpone their to menstruation, and they are given the hormonal drugs, and this is it is imposed on them by the employer. What can we do? The relevance of financial independence and decision making for a woman, in what way is it it contributes for women's autonomy and the dignity. And we also had this thing that the problems of what do we call as a psychosomatic issue, and there was a very interesting debate we had about quote unquote psychosomatic symptoms, which the doctors always, when women talk about the pain, and we had a very interesting debate on pain as such, and pain management, and what is the response of the modern medicine with regards to various types of aches and pains which the gender minorities face, women who go for surrogacy, they face, and how the medical, there are alternate therapies that we have. So I think it was a very engaging and a very energizing session we had. And today also, I'm sure it's going to be, with the way proactive participants are listening there. And most interesting thing was that they were there till the end. People did not drop out. All 41 were there right from the beginning till end, which is also makes our effort worth it. Thank you very much.
Thank you so much, ma'am. Now, with your permission, I would like to start today's session. I would request Professor Sanghamitra Acharya ji Professor, Center for Social Medicine and Community Health, Jawaharlal Nehru University, New Delhi, to start her session on the topic of pandemics, epidemics, and gendered healthcare system. Over to you, ma'am.
Thank you. Thank you so much, Fiza. And thank you to Team IMPRI under the guidance of Professor Vibhuti Patel to have organized this, this seminar or workshop, whatever. I think it goes very well with all these nomenclatures that we keep using for platforms such as these, where we get together to share ideas, especially with the young researchers. My task, as I have been assigned, is to diverge in the area of pandemics, epidemics, and how gendered healthcare system perhaps has encountered these experiences that we've had, particularly in the light of recent health emergency that we faced. Perhaps to begin with, let's try and understand what exactly pandemics and epidemics are, and also not to forget the endemic in between. Very, very common understanding of an epidemic is that, there's a disease outbreak, which is kind of rapidly spreading in some geographical space. Whereas pandemic seemingly is an epidemic, but it kind of covers a much larger expanse, multiple regions, perhaps across the global dimensions. And therefore, I think the context of pandemic certainly remains much larger in terms of addressing or understanding also, for that matter, how health systems will react to it. And all the more when we are talking in terms of the gendered health systems, how they would be impacted, how they would be influencing also. In the same context, I think when we talk in terms of the endemic, I think endemicity is more pertaining to the specific region. We may have specific, diseases which are very, very evident in certain geographical spaces. Now, in this backdrop, or this very, very basic understanding, I think it's important to get a sense of how did we cope up to begin with the recent most health emergency that we've already had an experience with. And that's why perhaps it's important to, I'm sure most of us would agree that COVID-19 had been something unprecedented in the sense that it really had almost a gap of 100 years if we compare with the previous one, what we know as Spanish flu. So perhaps the gaps, the time frame that we have, and how we as humanity tried to address that, tried to overcome that, for that matter. Perhaps if you look at COVID, the only way which was deemed possible to tackle this crisis was something into the tune of restricting the mobility of the people. And we see ourselves, constrained in terms of mobility when the stay-home policy comes as a lockdown. In fact, for us, the enforcement of staying home, I'm sure we are all, we've just experienced it, and I'm sure the memories are fresh in our mind. How relevant it was for many reasons. For sure, that at that time point, the amount of information that we have about the COVID-19, the way we were preparing ourselves to face that, I think it was perhaps that was the most probable way to address it. Of course, we have different opinions about it at the moment as the discourse has moved ahead. But then, that policy perhaps needs to be seen in the light of the fact that about 1/3 of the households really needed to accommodate 3, 4, 5 people, inside one room, and then with the realm of social distancing mandated as well, we can imagine what could have been the problems, how staying home could have evolved itself over such conditions. Therefore, I think what therefore becomes relevant to understand also when we're looking at women of different hues across these housing scenarios where we are getting clustered, in terms of whatever small or big space that is available to us was difficult, especially women who were working in informal sector, for instance. They were perhaps also hit by the fact that the jobs were being lost, not only theirs, but also perhaps their spouses, also perhaps the other family members. And therefore, I think it added to the burden which was anyway being projected vis-a-vis the spread of the disease per se. So I think, to my mind, therefore, it becomes very important to critically reflect on the ways in which the pandemic, for example, COVID-19, which I'm going to use as illustration, has affected and continued to affect women, particularly in India, and of course, realms will also connect with the global scenario. So I think to draw from a range of, let's say, qualitative and quantitative research, it's important to analyze what could have been the implications, what have been the implications on women who are homemakers, women who are workers in informal sector, women who are migrants who followed their spouses and have come to the urban spaces, who could be workers themselves, migrant workers themselves, who could be in the healthcare sector, who could be economically active in both rural and urban spaces, as left behind women, as women who are in spaces, places of destination. Women in the realms of, let's say, being young girls, women in terms of being elderly women, women who are providing care as educators, as perhaps counselors. The point I'm making, therefore, is women in their varied dimensions had to encounter historically the ways they have managed to address both pandemics and epidemics as they have appeared over space globally and across the country, for sure. And that's perhaps the point I'm therefore trying to make, is to be able to understand we need something of a multidisciplinary or interdisciplinary kind of engagement with scholars, with students, with policymakers in the field, where we can kind of connect with and make some dent over it. Therefore, I think just to perhaps concretize what I'm trying to say, when we look at what happened to women globally through this recent pandemic, if I quote the data from what we get from the documents which are United Nations documents which are dealing with health, which are dealing with gendered issues, COVID-19 seemingly has driven as many as 2 million women, particularly mothers and those who had young children, to consider having to change their workforce, or perhaps staying back at home, leaving their jobs away. And if we compare that in terms of how men and women have differed in terms of this decision, we see very, very evidently that there are more women who have had to make this choice as compared to men. And going back to the same data set, there is a difference of about 5 percentage points when we make these comparisons. So just to kind of therefore begin on that note, there have been the first perhaps hit has been on the livelihood structures that were there, which had brought men and women to move from largely rural backgrounds to urban spaces which were perceived as providing more better livelihoods. So the precarious livelihoods which were experienced because of COVID, I think that becomes very important for us to take note of. And we know that in many countries, we have evidences which reflect upon the fact that women, when it comes to the livelihood of women, they were put to risk in terms of being most severely affected. and if I go by the estimates of what Oxfam report tells us, 47 million women and girls have been pushed into extreme poverty since the pandemic descended. And if we inflate it further, 740 million women who work in the informal sector during the first 3 months of the pandemic, their incomes fell almost by 60%. So, while we talk about the pandemic hitting everybody across the globe, across the space, etc., we do get a sense that when it comes to women, they had a larger brunt to perhaps bear. They were excluded from the healthcare, quality healthcare, if I may say, and we've had ample evidences both by way of the care which was important for them as through the antenatal care, through birthing, through postnatal care, got affected because perhaps of the options that we seemingly don't kind of give women. As COVID-19, we all know, disrupted the health systems, and to meet the need of women in terms of their sexual and reproductive health, I think that was the first thing which gets affected. In fact, globally, women and girls, it has been reported that their access to care services was reduced, which in fact increased the if I may say, the risk of unwanted pregnancies, for example, sexually transmitted diseases, and of course the complications during pregnancy, during delivery, during termination of pregnancy. If I may again bank upon the data, there are global predictions of about 7 million unintended pregnancies worldwide, which kind of couldn't be contained because of the diversion of the services. And it is estimated that maternal deaths have increased between something to the tune of 8 to 39, almost 40% per month in low and middle income countries, largely because of COVID. And if, in fact, also we have evidences that more child marriages have occurred, particularly due to the school closures, the activities of the children themselves in terms of where they should have been getting education gets diverted to something very, very differently. At least 1 million pregnant schoolgirls across the globe risk losing their access to education, particularly in the sub-Saharan Africa, if I kind of take a call on what was happening beyond our regimes. With all of this, women also were responsible. In fact, they were, I'm not too sure if I can say they had an option otherwise, were shouldering the responsibility of providing care, also providing care to those who were affected. So when we think about women per se and their role in addressing the needs of the people during the pandemics historically and epidemics which have sporadically occurred over the period of time, women were pivotal by way of perhaps in the first instance picking up the very care activities, the care load in the clinics, care load in the homes, and even at the workplaces, I'm sure, was largely on the shoulders of the women. And I think we as human beings have also been socialized to believe that providing care is the nuance where we see women per se becoming crucial. So globally, in fact, women make up for 70% of health and social care workforce. And they are the ones who are also, most of them are engaging in domestic work services across the globe. But what's important, perhaps, while these jobs are essential for the pandemic and the epidemic both, they have really been undervalued because much of it is taken for granted because this is how you're socialized, therefore caregiving is your call. and therefore perhaps there is also the realm of poor, the wages remain low in this context. So putting these women as essential workers has really, it needs to be kind of addressed, and we need to take a call, in fact, in terms of the way these women get at greater risk, and therefore the preparedness that we are talking about for any future calamity such as this needs to kind of take a call on this, because 3/4 of women globally are the ones who are contributing to all unpaid care. They're the ones who constitute the total quantum of unpaid care, and they comprise of 2/3 of the paid care, which contributes trillions and trillions of dollars to perhaps the global economy. In fact, therefore, I think it is also important for us to take note of the fact that women therefore become fairly pivotal in context of what I'm trying to argue for is the invisibilization of the activities that women have engaged in terms of providing their share of attribute in terms of the needs which the pandemics and situations of pandemic and epidemic create for human beings. It's also important, therefore, to connect women's role in the household, women's role in terms of supplier of the food to the family. She is also, she may not be the breadwinner many a times, but she is the one who cooks. She is the one who makes the home. As homemaker, for example. So she also therefore plays a very crucial role in if I may say, the global food supply system for that matter. Not only as what I said, as a homemaker, where her role is to cook food, but she's also a participant in producing that food as an agricultural farmer, as a cultivator. She is also a worker who's processing perhaps that food. She could be in the plantation, she could be in an agro-based industry. Therefore, women are typically responsible for creating this product, and therefore buying and cooking for their families also as another role that they engage in. So we do see a very strong connect between what we imagine as food insecurity versus women in terms of the very, very focal point in the familial setup, which is women as a pivot versus the large scale context of the agro farm, agro industry, etc., etc. So with all in all of this background, despite her contribution, we see that the prevalence of food insecurity continues to be higher for women. And why does it happen? It has a lot to do with the processes of socialization, and we see this very, very strongly in context of the food which is served within the familial setups. So the Oxfam study, again, if I can quote their data, it works out to suggest that if women had the same access to produce resources as men, they could reduce the share of hungry people almost by 20%. And therefore, I think it's very important to take note of the fact that despite this contribution, if we see what was happening in terms of the loss of wages, both in the agriculture sector and outside the agriculture in rural and urban spaces, 40% of the total job losses were held by women. It was women who was bearing the larger brunt in terms of losing the livelihood probabilities. So I think, and we know very well that it's women who makes a very, very large they're the ones who constitute perhaps the largest share of the workers in the informal sector. So I think it really becomes very important for us to take note of this in all of this, yet another point which is coming to my mind is that of in all these roles that I'm trying perhaps to argue for, and as the newspapers have also suggested, there was a surge of gender-based violence. We saw through the recent post-health emergency that violence against women and children had increased rapidly, despite the fact that most of us as nations have kind of believed that we are being more human and more civilized, and we don't engage in these activities. Again, going by the adages that we, I'm sure, read in literature, in stories, etc., etc. But then COVID does gives us that reflection. Perhaps the very policy of staying home was also responsible for generating the kind of stresses and anxieties among the people, which led to this kind of scenarios. Almost 34% increase was reported in intimate partner violence during this time, particularly in the initial first year, 2020. If you look at that data, there were 31 million additional gender-based violence cases which were reported globally by July 2020. So, so I think the point therefore I'm making is, if we connect the larger global scenario with what was happening to women in India, we all, all of a sudden, late March 24th, I think, if I recall correctly, 2020, we get locked down. The stay-home policy becomes functional, and we are not supposed to be moving anymore. So, although perhaps we weren't, most of us, I'm sure, almost all of us weren't prepared for it. We see it in terms of what was happening to the migrant population. We do see that a lot of these shutdown impact of the lockdown was, not only all of us as citizens of the country was experiencing, but in our roles as physicians, in our roles as workers. And particularly if we bring women on board, I think women physicians, women workers, perhaps for them the challenge was particularly, it was enhanced. To be able to continue to provide medical care, for example, to be able to provide the kind of counseling that was required, and also manage the domestic responsibilities, I think was something which was a Herculean task. Women were very, very, almost at par with men in terms of extending these services. While we know that women around the world, especially the mothers, especially the young mothers, irrespective of whether they were working or not working, like I said earlier, have been traditionally the primary caregivers. At least that's what the notion is. So we assume that there'll be some kind of multitasking that we, in perhaps some sense, take pride of it also. Will be able to cope up with the household chores, the child care, the elderly care, their own jobs to address vis-a-vis online portals that became active. All of this was happening without any additional support. Obviously, we couldn't have offered any, particularly in the light of stay-home policy. In fact, most of the urban households in the country, especially those wherein working women were, and I'm sure most of us have experienced it too, necessarily we rely on some kind of extended family or a domestic support, domestic help that could be supporting us. It could be any varied forms that we make use of this. But during the lockdown, we know that as women of the house, all these jobs, in addition to the earning work, came up to us. So from earning to domestic to care, all three major activities were on women. And in fact, there are a good number of studies by now that suggest women in medicine seemingly shouldered additional burden as compared to men who were also in medicine, for that matter. So and in fact, one of these studies from one of the National Institutes of Health Sciences seemingly worked out a study which suggests that 8.5 hour more contribution was from women in terms of per week, that is, in terms of parenting and domestic activities that were engaging in as compared to their equivalent men otherwise. So I think that that probably brings us to in some sense get a sense of how these roles and responsibilities differed, when we almost always believe that both men and everybody was affected by the pandemic. So in fact, if I get to what some of the comparative studies across the countries have been kind of suggesting, in these backdrops, the studies which have been undertaken, or the data that has been reviewed, generated by different countries, is kind of suggesting that the pandemics have historically widened the gender disparity and have affected women more adversely as compared to women, even in the cohorts which are seemingly of the care providers, especially if we even when we see the hierarchy of the care providers as physicians, the divide is more, the gap is more as compared to the care providers who are at the local rung. In fact, so just to quote just one data from the Medical Council of India, there were more than 1 million registered medical practitioners which were registered, medical practitioners which were registered by the MCI in 2017, and out of which about 28% were women. But then while we do not have data to suggest the impact on subsequent registrations, the assumption is that because of the lockdown, when the domestic burdens were largely being shouldered by women physicians, there is a likelihood that the context of registration, updating the registration, may not really have happened. So this, of course, needs to be further investigated for sure. Therefore, if we take this as an argument and relate it to what was happening to other pandemics as and when they arrived, Ebola, for example, during 2014, or Zika virus during 2015-16. In fact, the factors such as proportion of health workers, proportion of home-based workers, proportion of caregivers, they seemingly have impacted, given some idea of how individuals could have been infected by the virus. How far, in fact, COVID-19 has created a lopsided footprint when it comes to India, we probably are still getting a sense of. But then, given the literature which has been generated by now, I would strongly want to suggest that there's nothing that would question the lopsidedness in terms of the gendered imbalance that it is suggestive of. Also, because if we take note of the fact that almost 70% of the global healthcare and social work is conducted by women, which also means, therefore, they are not only the first respondents to kind of take care of the outbreak, whether it is in the form of the epidemic or pandemic, but also they are the frontline workers to connect with the instances as they are happening. Particularly if I rely on the national sample survey, our own national sample survey, the 60th round, which was on employment in India, it very clearly estimates that health workforce shows that qualified women health workers constitute almost half of the total qualified workforce. And among these workers, I think qualified nurses and midwives have dominated almost at 89-90%. So while we see that this cadre of healthcare providers is largely women, it also reinforces the psychosocial realm of women being the care providers per se. So when we go back to this whole aspect of working from home, staying home, and how that impacts women, I think the whole idea of the extended burden that women were experiencing, although it was being suggested that this is the time that you're getting to spend with the family, etc., in all of that, the burden on women as caregiver, the burden on women as a bread earner, the burden on women as an individual per se had tremendously increased, because additionally, when she had to do jobs which she wasn't doing otherwise, I think made a lot of difference. Also, I think it started during COVID itself, when most of the states wanted the ASHAs, the accredited social health activists, and the Anganwadi workers to do the house-to-house kind of surveillance and make sure that the symptoms, etc., are noted down and people send for care, etc., etc. I think that itself was exposing these women who were the grassroots level providers to the health, to the spread and getting the infection for themselves. So the grassroots level workers' vulnerability was perhaps, to my mind, a little more than those of us who were sitting at the higher realms of the work hierarchy. In fact, and that also perhaps connects me with the idea of how when we look at women who are home-based workers, particularly in our case, women who are self-employed, petty shops, etc., etc., I think they were also affected by what the stay home and lockdown did to us. 32% of women in non-agriculture sector were basically doing home-based activities, compared to about 11% of men. So it certainly, they would have been almost 1:3 times more impact on women as compared to men. So when all of this was happening, and we want to kind of what I alluded to in the beginning was in terms of how the access to health and health with specific needs beyond reproductive health, for sure, although that takes a predominance. Many a times, like I said, despite the fact that we have a strong thrust on maternal and child health, women's needs became perhaps secondary to the realms where the services were diverted to address the COVID scenarios. In fact, large-scale disease outbreaks are known to have exacerbated the contexts of reproductive and reproductive health services. Although we may not have exact numerical figures to kind of suggest that, but as much as my information goes, literature is evolving on this to kind of give us some kind of idea in this sense. Also because when we're talking about pregnant women per se, their vulnerabilities in terms of the health concerns are many-fold more than the women who are outside those remnants. For instance, during the outbreak of Ebola, it was observed that there was a general lack of knowledge about how the virus is affecting people, as it was for COVID also. And therefore, what was evident that frontline health workers, such as midwives, they were really struggling to get the guidelines in order to take their jobs, further. And also, I mean, therefore, I think what also becomes important for to contextualize for ourselves in amidst the comparatively higher maternal mortality rates, particularly due to the, if I may say, absence of required ANC and lack of perhaps skilled care providers, COVID did make the preparedness a little difficult, and fairly much it has been indicated in our large data sets. So I think what therefore becomes important to take a call on is that, to my mind, as much as I would want to argue based on the understanding, women have perhaps been pivotal in terms of addressing the needs of the pandemics and epidemics. A lot of global response to such events has been by women, but these responses, to my mind, have not really considered the gendered and intersectional impact, because when it comes to women in poverty, their vulnerabilities, their concerns and realms wherein they're discriminated because of their gender, because of their social identity, caste, race, age, etc., etc., they have remained more vulnerable for sure. And therefore, to address this gap, I think it becomes very, very important that we take a call when these differentials, these disparities necessarily need to be addressed from the decision-making perspectives of any such health emergency that we may envisage, both at national and regional level, and as well as perhaps at the international level. Also because when you look at these events, particularly pandemic, for example, they also have a very strong impact on civic spaces. I mean, the whole public space gets abandoned because of the calamities such as these. It limits the ability for women's right organization, if I may say so, to argue for anything which is pertaining to their rights. For example, if I had to be locked with an abusive family or abusive partner in a staying home kind of policy, it was difficult for me to be salvaged by any such civil organization, socially conscious person, etc., etc. So I think that becomes really important for us to take note of, therefore, in terms of being able to connect how women per se have been influenced and have impacted the context of, if I may say, pandemics and epidemics. I think I'm going to stop here, and thank you very much. Professor Patel, over to you.
Thank you so much, ma'am, for such a detailed and insightful session.
Yeah.
I request Vibhuti ma'am to give us her remarks.
Yeah. Thank you, Professor Sanghamitra, Acharya, for very comprehensive and also connecting the dots when it comes to the whole question of intersectionality of vulnerabilities of women in different cohorts, whether they are housewives or women workers or those who are moving or women migrant workers. You also talked about the women as health seekers, the kind of problems they faced, and women as health workers, and also the question of how the state, even though those who are employed by the state, how are they treated? For example, ASHA workers or Anganwadi workers. And the very important learning of your lecture is that we need to consider women, when you ended that, you said that they are pivotal to this kind of addressing the health emergency, both as a healthcare provider, frontline healthcare provider, primary provider as homemakers, and also when their personal needs, for example, reproductive childhood, pregnant women's needs, and also the nutritional needs. NFHS 5 data are showing very, very deplorable reality of massive malnutrition, morbidity, and of both women and children. So I think it's a very important, and the most important point in that is that the women's role in decision making at every level, whether they are the healthcare workers, nurses, doctors, technicians, scientists. I think they have to play, when they are the 70% of the workforce in the healthcare system, why don't they have any say? So the leadership, the question of decision making, not only representation, but also voice of women. That's very important. And I think as compared to Ebola, for Ebola, there were not so many researches were done. But one good thing is that whether women scientists, because there was recently TIFR had organized women in physics, no? And there also the question of pandemic and how it impacted population. And they did not were stuck only to what happened to women scientists, but they were also larger concerned about women in different sectors of the economy and society. So I think it's a very, very important lessons that we get from your thing. And there are many, many questions now. I think where
Ma'am, Sasha
yeah.
She has raised her hand.
Yeah.
Sasha Necharati, yeah.
Hi, ma'am. Thank you for the insightful session. I actually wanted to develop on that the fact
Madam,
that
you introduce yourself.
Yes,
What do you do?
I am Sasha. I am actually a public relations consultant for social impact organizations.
Okay.
So I very closely work with organizations like Save the Children, Eagle Foundation, and everybody. Live Love Laugh Foundation, for example, to talk around rural mental health, gender-based violence, public health, women empowerment. All of these things I take care of with big social impact organizations. And that is where I want to develop through your session as well, that almost every event or crisis, a big event or crisis, would have a conversation around malnutrition and gender-based violence. For example, even if we go outside healthcare for a bit and take any war, a Syrian war that is ongoing, the issues of gender-based violence are the first ones that come up. So is there any way that we have a special task force to address this from the initial stages itself? Like, for example, India helped other countries to salvage the Indian persons in other countries as well. There are special task force like that. Is there any way that a gender-based violence issue can be salvage, or maybe reduce, we can reduce the risk through some task force? Because this also gets added that social impact organizations that are supposed to take care of this are the ones who struggle to survive during these events. So even they are having lack of resources, they are having staffing issues. So you're not able to address it. The social impact organizations sometimes are not able to address it. So is there any way, or how would you envision that a special task force can be taken, developed to take this matter ahead in the initial stages itself?
Do I take this question or?
Yeah.
Okay. Sasha, you've raised something which is very, very pertinent, particularly what you said very rightly. We do show our concern for both malnutrition and domestic violence. They probably become the crux of the conversation. Just to share with you, I'm sure many of us would be familiar, when we go back to our recent most health emergency, the COVID-19 Economic Response Task Force, although was headed by the finance minister who is a woman, we just had 2 other women members in this whole COVID scenario, COVID task force. So when we talk of in fact, that's the point I'm trying to argue, and Prof. Patel put it very simply and very clearly, that while you're engaging into the realms of 70+ share of the total workforce, but when it comes to decision making, this is where we are. Therefore, when we come to what you were saying, Shasha, can we have a task force, etc., etc. Now, if I kind of take from what the state has been doing, state has kind of, if I get to the recent most, the pink boots that we have in terms of policing, the helplines that we have in terms of, being able to make a call. But we all know the issues which are there, both with the pink boots as well as with the telephone calls. Half of the time we have realized that they don't remain functional, half the time they're engaged, and the context of being able to go and express yourself in a pink booth itself is perhaps a huge task. But I do agree with you in totality that there is a need to evolve this conversation and take it further, because on the one hand, we put women on a pedestal. We put her on a pedestal where we are supposed to be offering our prayers, etc., etc. On the other hand, we have violence, which is kind of almost an everyday affair for her. So offhand, to my mind, what has already been there, we've had the context of gender budgeting in most institutions. We've had the context of, reservation for women, for that matter. Of course, it's a different matter altogether that we are still not there in terms of implementing it. The point I'm therefore making is, while there are certain things in place by way of policy, by way of, planning the context, but the implementation remains a bit of a question. So yes, there are some things which we have moved ahead, and some things where we really haven't moved ahead, and we need to move ahead. I think I'll stop here. I can see Anushka's hand up.
Yes, ma'am. Anushka?
Hi, ma'am. Lovely session. I just have a couple of a question. Now, when we're talking about women in the health force, especially now, let's break it down to nurses and people who are like direct in contact with the patients, especially because they are women in most of the population.
Anushka, please introduce your work.
Hi, ma'am. I am Anushka. I'm doing my second year in social work, Bachelor's of Social Work. And so now, do we have any proper care system or policies for them? Because most of the times, because they are in direct impact from the patients, we do see them getting sick a lot, or they can't make it to the hospital for certain reasons. Do they have like a proper union for them? Because for other sectors, we do see a lot of labor unions. But for them, do they have proper unions, labor law policies, or like even general healthcare concerns for them available?
Anushka, as much as I know about the unions per se, the nomenclatures could differ, but nurses, for sure, the cadre of nurses do have unions wherein a lot of these concerns are addressed, taken care of, or at least tabled. And I say this also because in the light of contractualization of nurses, particularly, it was important for such bodies to come and raise their voices. And these bodies are very, very active, particularly if we go by three of them, the ones I'm familiar with, in terms of raising the issue of differential wages between contractual and non-contractual workers, between those who are in the private sector hospitals versus those who are in the private sector, and also the hierarchy of the level at which the care is being provided. So there are institutions. They have been talking about the social security realms also. So are the groups of the physicians. But my apprehension is that the word union per se is not really used, although within institutions the groups do use the nomenclature.
Associations are there. All
Associations are there, yes.
And also the associations of Anganwadi workers and Asha workers, they are also very powerful, and they have all India base. And during the pandemic also, they raised so many questions, and there were strikes also about that.
Yeah, Anganwadi workers, and yeah, you're right. The whole of Delhi was, these workers had to be really, they had to actually get down to strike to be able to hurt for small things.
No,
so sorry.
Not treated as a worker, not given minimum wages, treated as a volunteer, and volunteering for 16 hours a day, 12 hours a day, without any personal protection equipment, directly. The hazardous, so many deaths have taken place which are not even reported. Only we have those who community-based organizations who were in touch with them, they know that, but we don't even have data of how many of them have died. No? Like we have data about doctors and nurses who have died, but about the Asha and Anganwadi workers and sanitation workers, we don't have. Only that Akhil Bharatiya Safai Karmachari Sangatna
And the way all these women who had to burn because I was there in a lok adalat, people's court, where they were reporting these women who had to burn the bodies which were flown into the river, and all these bodies, they went in the river Ganga and all other rivers, and the villages which touched this river and where the bodies were found, they were forced to burn the body. They were not even told whether these are the bodies of COVID people who were infected with COVID or not. So,
in fact, similarly, even at the crematoriums and burial grounds, the small work that we've kind of engaged with showed a similar kind of, issues. So, Anushka, I hope you've got some clue to the question you posed from both Prof. Patel and what I tried to add to.
Yes, ma'am. Thank you so much.
These are the gray areas on which we need to work, because they are invisibilized, no? So we need to make them visibilized. Their voice has to be amplified. The chat box, open it.
Ma'am, there's one more question from Anushri.
Yeah.
Anushri ji, you can ask the question.
Yeah.
Hello, good evening, ma'am. I'm Anushri. I'm early career faculty. So my question is probably in line, in continuation with the previous question. Now, which means, like, if we are talking about contract and non-contract nurses, or even for that matter, doctors, which basically means that they're in a formal sector, but then an informal employee in that realm, right? So then do we really have to look at minimum wage rate for them as well? Like, and what's your take on that?
I would say yes, of course, because Anushri, as a professional care provider, there is a certain realm which should govern me, right? And that's precisely why we make that distinction between formal and informal sector. So if the contractualization is informalizing the formal sector, then there is an issue that we need to address. Also, because it's the market forces which are coming in very, very vibrantly to get onto this. So I would probably believe and work towards how the contractualization, if at all has to happen, should be laid down very, very clearly in terms of the do's and the don'ts. That TOR for contractualization necessarily should be at par, which does not discriminate in terms of working hours, in terms of workload, in terms of the wages. The three most important things that we often tend to think about when it comes to contractualization of any labor for that.
No, and the work which is regularly, daily required, why should you have contractualization?
Contractual, exactly.
If it's only emergency for 6 weeks or 8 weeks or some disaster and 50, then one can understand the casualization. But when the work of Anganwadi and health workers is a day in and day out, no, then why not regularize them? No.
Absolutely.
I have one more question, if I may.
Please go ahead.
Yes.
Introduce yourself.
Same, Anushri.
Yeah.
Yeah. My question is, now, given that we have different types of health systems, and while there's less, harmonization between these health systems, right? In a country like India, how would we really look at probably facing another pandemic or any other outbreak? Which also, the reason I'm asking this question is, it also leads to a whole lot of informal medical system which is running with the coax. Yeah.
I think I would also request Professor Sanghamitra Acharya to deconstruct the term quack.
Yes, thank you, Professor Patel, for bringing that in. In fact, Anushri, this is very, very important that we revisit some of these existing terminologies. When we've been using this term, it was almost suggestive of the fact that one isn't a trained professional and therefore not eligible to provide care. But then this has actually metamorphosed to be used for indigenous system, local healing practitioners. while I would probably want to draw your attention towards some of us who are in the formal modern medical system, and we are not doing what we are expected to do in terms of providing care, in terms of the fee that we are charging, in terms of the time that we are giving to the care seeker. So please be very conscious of using the term court. Also, because we now have a full-fledged ministry, which is of Ayush, wherein we are talking about the the indigenous systems which are there, or let me say the medical pluralism which is coming in, and I would rather say healthcare pluralism rather than medical pluralism. And I'm making this very clear for us, Anushri, because in a village where we have individual, let's say the village wise men or women, who's been providing care for perhaps donkey's years. And this is the knowledge, which is the knowledge of the community, which has been learned from one generation to the other, and so on, is where we locate the ownership of knowledge, and therefore the transmission of that knowledge vis-a-vis the trust that the care seeker has vis-a-vis the person who's providing the care. I know my village wise men or women, and therefore I believe, I have faith in the services that would be provided to the thing. And I'm just trying to quote from one of my students' field work in Bundelkhand region of UP. Here is this very impoverished bone setter, women bone setter, again a rare species, which is where when the student asked her, what is it that you charge for setting the bone? She was aghast. She said, have you gone crazy? Will I ask for money for somebody who's already in pain? Now, this is the ethics of practice.
Right.
Unlike the ethics, if you transport that into the tertiary sector private care providers here in the metropolitan cities, right? If you don't have the money to pay, you can't even take your dead kin who's kind of passed away, perhaps because of medical negligence, right? So the point therefore I'm making is what you've raised is extremely, extremely important, but usage of terminologies have to be very, very carefully said. And therefore, when you say different systems are there, therefore, how do we address that? It's very important. See, when illness and disease occur, when death is standing in front of us, we want to make use of all possible strategies, all possible care provisioning that we can from all sources. And therefore, perhaps to me, relying upon one sector may be what we need to question. Also, because when we talk about modern medical systems, economic propensities become very, very important, again, in context of the public and the private sector that is providing the same kind of care. The same kind of care, the same kind of care provider, the market factors start becoming so very important when it is in the private sector versus when it is in the public sector. Over and above that, we have traditions of different medical practices, healthcare giving practices, from Siddha to Unani to homeopathy to Sigva, I mean, whole lot of systems that we have kind of assimilated. That's perhaps where we are in terms of the diverse, systems in which we exist. Over and above that, the little local traditions that we have, a local village headmen or women that I was talking about will be very familiar with that indigenous region where that village could be located or that region could be there. Something which is practiced in Northeast could be very different from what it would be practiced in Kerala, also because the nature of medicinal plants, for example, will be different. The natural vegetation is different, what we see in the peninsular India versus northeastern hills. So there is a need perhaps to bring all of this together, but I don't much agree with what has been talked about in the discourse very much in terms of the codification and certification. Codification, yes, we do need to list out for perhaps posterity, but certification is something which I am a little wary of, for the simple reason, when we are talking of the knowledge of traditions, knowledge transfer from one generation to the other generation, being certified by a knowledge, knowledge space of something which has been acquired over a span of perhaps 5 years or 6 years or 7 years, I have a bit of discomfort in that. Why do we not have belief in something which has existed over generations? The process should be to kind of standardize that in some sense, rather than getting it certified by somebody who has no inkling whatsoever about how this transfer of traditions of knowledge could be happening. I'll stop here, Prof. Patel.
Yeah, thank you. Thank you. Very rich discussion.
I think there is
Ma'am,
Shruti.
yes, ma'am. Shruti
Um,
Sharma.
Yes, good evening, Professor Patel and Professor Acharya. Thank you for your talk today, Professor Acharya. I'm Dr. Shruti. I'm leading the Medical Affairs Department for a leading healthcare MNC, and I'm working on establishing certain minimally invasive procedures, mostly in the women health domain. So I would want to base my question today, Professor Acharya, on this point from your talk, which said, that COVID definitely impacted the education setup as well. A lot of schools were closed. And when I look at health in particular, it goes hand in hand with the education level, the right to health and the call for that right definitely proportionates to the education level. So my question would be that how do you take a call on this, the lack of education with respect to the right to health? And from a policy perspective, is there a vested interest in this awareness and the education, mostly from a digital media, because that gives us a wide reach to the audiences, and because everyone has a access to that technology right now? So what is ideally the take on that at this current stage, Professor Acharya?
Thank you, Shruti. You have actually invoked another session to my mind, but I'll try to kind of give a sense of what I have understood from your point. Like I said, women in their role of care providers don't function in isolation. As care providers, they are also playing a role of a mother, of a spouse, of a homemaker, of a caregiver to the children who are going to school and whose classes are being held online. So they have to do their classes as well as their own job on their respective portals. And if they have elderly family members and the family, all the elder care that they have to provide for. Now, in these varied roles, the point that you are bringing in, how do we connect that sense of differential roles women could be attributed to, and therefore how do we see it in terms of the policies? Now, medical education per se, let me just bring you there. When you look at the options that medical education provides for girls, I'm sure you yourself, a medical professional, you know that there is a very neat kind of divide in terms of what kind of specialization men will offer versus women. For example, when we look at pathology, for example, surgery, for instance, largely you'll have larger share of men being men in those specializations as compared to pediatrics and gynae, and again to the larger realm of soft skills versus hard skill kind of an argument. So the point is, if you're really addressing the policy context of such an divide or such a realm, to my mind, what also becomes important is to connect this with the very socialization process. And that brings us back to how do we see our boys and our girls making those choices that could be that could minimize this gap. As parents, what is it that we expect out of them, and therefore what is it that we gear them towards? Right. So to me, I think it begins right from there. option of courses for that matter, even before you get into the professional higher education institutions, the courses at school level, class 10, 12, etc., maths versus biology, for example, economics versus psychology or sociology for that matter. So I think what perhaps policy needs to come to is to connect the processes which are creating these gaps, if I may say so, to the societal processes wherein we locate perhaps the family, the society, the community. So I would think that's perhaps a response to your poser in a more abstract forms, but we can kind of focus it towards fairly, nuanced specificities given what you're posing to me. I'll stop here.
Thank you so much, Professor Acharya. Thank you so much.
Anushriji, you can ask your question.
Sorry, I have no more question.
So any other question from the participants?
I think we have exceeded the time limit. We are eating on Professor Ramanathan's time. So
yeah, we can move to next, Fiza.
Yeah.
Moving forward, I would request
Professor Sanghamitra. Yeah, thank you. Yeah.
I would request Professor Mala Ramanathan, Professor, Acharya Menon, Center for Health Science Studies, SCTI-MST, Trivandrum, Working Editor, Indian Journal of Medical Ethics, IJME, to start with her session on visibility of gender in health, statistics and health indicators. Over to you, ma'am.
Thank you very much to the IMPRI team for giving me this chance to put together this presentation, because very often we think that capturing gender is something that is very easily available, and we can find out the gender differences. But it's not such a simple exercise, and that is precisely what I would like to talk about today. And when I put together the data, I realized that there are, yes, gender gaps exist, but there are gender gaps in our ability to assemble meaningful indicators, even though we have the statistics for it. So that's another story, which is what I propose to highlight. Is it okay if I share my slides?
Yes, ma'am.
Is it working, ma'am? Yeah.
Is okay?
Yes, ma'am, you can go full screen.
Yeah, just give me a minute. For some reason, my mouse is 1 minute, please. Okay, is it on full screen?
Perfect, ma'am. Please go ahead.
Okay. So, see, visibility of gender in health statistics and health indicators is what the topic that I have, and I am going to be showing you a lot of fine print, and I apologize at the beginning for that, because it was impossible to make a lot of, people from diverse audience to know the kind of, data sources that we have and what those data sources look like. As a consequence, it's going to, give some of you a headache, and I'm apologizing in advance for that. As usual, the opinions expressed in this presentation are my own. Do not represent those of the institutions to which I am affiliated. And the aim of this presentation is very simple, to enable you to recognize the sources of health statistics in India, to enable the development of gender indicators using these sources of health statistics, to understand what these indicators demonstrate regarding, variations, and to see if there is any need for additional data or resources to discern inequitable gender differentials beyond sex differentials. Because merely the fact that there is a difference between men and women in certain indicators doesn't necessarily mean that's a bad thing. Like, women don't get prostate cancer. We can't be saying we want equity and stuff like that. So, or, women do live longer. Question then to ask is, why don't men live longer? Not necessarily why do women live longer. You get it? Some of it is partly biological. And so we need to be able to recognize those things as well. So what do we mean? What are these health statistics and what are health indicators? Health statistics consists of data regarding health outcomes or health status compiled from different sources. Now, it could be like, across space, meaning you could have that data for different countries. That statistics could be for, the same country across time, or it could be for different states in India. It could be for anything. But these numbers may not be necessarily meaningful unless they form part of a series or are converted to indicators. For instance, if I told you there are 200 births in Mumbai today, 400 births in Kolkata, and 600 births in Delhi, what does that mean? So you have the health statistics provided every day. This is your health statistic. It doesn't have a meaning unless I convert it to a rate per day to enable you to how many women were pregnant who delivered today. Oh, so this many. How many women were available to deliver in a particular period? That is the denominator. Then you get a rate out of it that enables you to see whether Mumbai or Delhi or Kolkata are having similar rates, or is one state, one metro ahead of the other. So number of deaths due to COVID in a state. So there were 400 deaths in state A. There were 600 deaths in state B. No, but supposing there were 1,000 people in state A and 1,000 people in state B, then it is 4 out of 100. 4 divided by 10, so 0.4 in one place and 0.6. Then you can say, yes, 0.6 is higher. But if there was, in the 6, there was 1,200 people living, of which 600 died. And in the first place, there was 400 people who died, but there were, let us say, 1,600 people living. Then, unless I give you how many people were living among whom certain number of people died, it's not meaningful. Just going around saying 600 people died, 400 people died, and very often in newspapers, this is what we hear. They say, oh, there were bodies found floating in the Ganga. 200 bodies were found floating in the Ganga. How many bodies were there for which we did not have sufficient burial or cremation facilities, which were then floated in the Ganga? No, that question we won't ask. We will, yes, it is very bad that bodies floated in the Ganga. That is not a good thing. But, before we jump, anything is a rights issue. Yes, it is a rights issue. But then when you want to compare this state with that state or this situation with another situation, you need to convert it to indicators, and that's what it is. Health indicators, therefore, are meaningful numbers or status markers which indicate the position of an individual or a group with respect to health status. This also could be across space and time, but will be meaningful, and that will therefore lend itself to comparison. Mortality rate in a state due to COVID and other causes in a state in a specific year, birth rate of a country in a specific year, survival rate for COVID in a particular state in 2021. Now that you can compare, no, this was the survival rate in Kerala, that was the survival rate in Andhra Pradesh, like that. Then you can compare. That is precisely why we need to carefully think about health indicators. I'm sorry, I need to share again. It got stuck. Just give me a minute.
We can see it, ma'am. Yeah.
Yeah, okay. Can I go ahead?
Yes, ma'am.
Okay.
Yeah. Yes.
So what are the sources of information? Oftentimes, the sources of data for both health statistics and health indicators are the same. Organizations, in India, government data, all people report on statistics, and sometimes those organizations convert them to indicators and they have a predetermined methodology. But what happens is this methodology is sometimes written in fine print or not written in the tables, but written as a prelude to the tables or as an addendum to the tables. Hardly, how very often when we sign anything, we read the fine print. I challenge most of you. Do we actually sit and read the fine print? Guys, you can tell me, there must be some rare person. Hello, guys. बहुत देर हो गई है और सब लोग सो गए. Okay, so there are agencies that collect data on health, including the Government of India, state governments, survey agencies of the Government of India, and National Sample Survey Organization. All of them collect and compile data in the form of statistics and indicators. In addition, you must remember there are other sources that are privately supported, like IndiaStat, but they are not open source data like that from the government, where there is a very systematic effort to go even beyond these, dashboards to giving you Excel sheets, data. In fact, we live in an era where we have so much data, but no information or understanding. That is the problem that we need to overcome in a systematic way. And I hope, these kind of efforts which all of us are making help us to move in that direction. Now, specific data sources, I'm giving you a few, there are far more. We have Census of India, which was supposed to happen in 2021, but maybe it will happen next year or something. And we have, under the Census Commissioner of India, the sample registration system. Then we have Ministry of Health and what do you call this? This sample registration system and SRS are under the Ministry of Home Affairs. Then we have National Family Health Surveys, NFHS. Everybody keeps saying NFHS said this, NFHS said that. Now that is coming under the Ministry of Health and Family Welfare, Government of India. Then we have another resource that is called the National Sample Survey Organization, which comes under the Ministry of Statistics and Program Implementation of the Government of India. In addition, if you think it only gives you survey, the Ministry of Health and Family Welfare also provides HMIS data which is, ongoing health statistics, Health Ministry's ongoing health statistics, which you can, is uploaded by different state governments on different programs on a live basis. So you can check that data, though, there is a time limit up to which, but I find that that data is also an excellent resource because it tells you the extent to which the reporting has occurred. How many are reporting institutions and how many have actually reported. Just a minute, please. Just a minute. Go and respond because they would continue to ring. This is a festival season and everybody thinks.
Yeah, no,
the
it's
proper
Onam. And we are
Yeah.
also thankful to you that it being a Onam for you, very important you have joined. That shows your commitment. Yeah.
So you see, the Census of India website looks like this. This is what I meant. I don't mean to irritate all of you guys, but please take a look at it. It gives you number of villages, towns, households, population and area, India and states, union territories, districts and sub-districts for 2011. When 2021 or 2024 or whatever census comes, we will get this decadal variation in population. Then it comes in Hindi, villages by population size class. Then it gives appendix. So if you go there under each section, state by state, all India, you will get a plethora of data. In addition, we have the sample registration system, which is a panel that is set up once in 10 years, which provides birth and death rates. Because when India, was a nascent country, we didn't have enough people reporting on births and deaths. How much ever effort we keep saying and don't punish people for not, registering births and deaths, it still was a little, not fully on par. As a consequence, we have, set up a sample registration system which provides us with state level rural urban birth and death rates, as you can see in this figure. And if you go on to the Census of India website, you will get that as well. So do we not have statistics? We have statistics, we have indicators. Then we have the National Family Health Survey, which gives you fact sheets and it gives you, data. If you apply with a specific reason, they will supply you with access to the data. Then we have the National Sample Survey Organization. You remember I mentioned it. If you go there, all the reports and the National Sample Survey Organization its basic job seems to be a lot of economic data. Expenditure, household expenditure, and consumer expenditure. All of this and our, annual growth, etc. When Dr. Nirmala Sitharaman talks about all these things, some of the data comes from NSSO, which they use to, plan budgets and everything. So that is the importance of NSSO. And within that, we have, can you see, multiple indicator survey, kinds of things like this, which give you data on health as well. See, this is key indicators of social consumption in India, health. Now, this used to be repeated once in 10 years, then it became once in 5 years. So I've just taken one as a sample for you people. Now, if you think, then we have HMIS data and just look at the extent of detailing that just the print screen is giving you total number of maternal deaths across years, total facility-based maternal death reviews done, percentage of adult inpatients to total adult inpatients. Did any of you even know such things exist? Guys, gentlemen, ladies?
Now they will sleep.
They went to sleep?
No.
Numbers, when you show numbers, people tend to sleep. Hello? Okay, maybe they are waiting for it to be over.
Yeah.
I promise not to take a lot of time, but I wanted you guys to be a bit more interactive to enable you to, work your way through this.
Yeah,
So
Dr. Ramanathan, the format is that you speak for 25 minutes. After that, they will inundate you with the questions.
Okay,
Because
so
it's a
this
very,
is,
yeah.
okay, so there we have,
No, ma'am, we are right here. This is really interesting. That is the response of Dr. Shruti Sharma. She's a medical practitioner.
I've eaten a lot of time from Mala's share.
no,
Yeah,
that's
I know.
okay. Now then you have to also realize that when death is registered in the civil registration system, some of them come from hospitals which are registered for reporting on cause of death, which are registered. State governments in some places have only registered medical colleges. Some state governments have registered population research, PRCs, primary health centers. So different states have different reporting. So what extent reporting happened and what is the completion of this record of the total deaths? This report on medical certification of cause of death, the latest version is 2020, and this also is available. So what kind of health statistics or indicators are available? For a start, I showed you population counts by sex across different characteristics like, age, sex, rural, urban, educated, illiterate, occupy, employed, different kinds of employment, by, religious, sometimes by marital status. There is a volume of data in the census which gives us denominators to compute rates. Then we have mortality and morbidity statistics by sex. Sometimes these statistics are also available across characteristics like caste, occupation, wealth quintiles, etc. Such cross classification helps us to look at the identification of gender gaps in health, if any. In addition, we may also need to recognize which of these gaps are biologically determined and which are not. And only then can there be a thrust for public policy interventions. Look at the census. Does it not at least start by giving you male, female total? It says persons, male, females. We may quibble about the missing transgender, but it is giving you a total count of India's population across states by age, by sex, by marital status. And this is repeated time and again for different categories. No? Then, can you see? Household size, total number of female headed. It gives you information on female headed households. What is the nature of the household status? How many rooms were there? How many households? What was the household size? Whether there was an exclusive room or not. Look at the extent of detailing for female-headed households that you have. Then if you think the SRS bulletin only gives rural-urban death rates, no, it gives you male-female. It gives you death rates by sex for rural-urban across states. It gives you infant mortality rate by male-female, particularly because we were beset by problems of, attempts at heightened, female infant deaths. There was an effort made to systematically monitor, and here it is. Here is the data and the indicator. No, this is not a random number. This is a comparable rate called the infant mortality rate, which is computed in a standardized manner. If you think it is only about mortality, we have also, in the National Sample Survey, the reports I showed you, proportion of persons who were having an ailment or more during the last 15 days by different age groups for gender and rural urban. And you can see that this kind of data, if you are able to do analysis, is easily available for anyone for free. It is not that they are going to ask you any money. Earlier, they used to say, give CD, this, that, nothing. It's all now freely downloadable. If you think the medical certification of cause of death is not by segregated at least by sex, that is also not. They give it to you by sex because some diseases only women are prone, some diseases only men are prone. So just look at it. NSSO 71st round, look at the way the data is. Now look at it. Now you look at allopathic treatment for men, allopathic treatment for women. People who got no treatment at all in Andhra Pradesh. 1.1% of the men got no treatment at all when they had a spell of ailment, whereas 4% of the women got no treatment at all. Does that not tell a gendered story? No? So there is a lot of data. Will health statistics by sex help to develop these gendered indicators? It's a very good starting. The data to make this start is there. I've shown you to the extent possible in this limited time that this data exists. But developing indicators in health that are gendered asks, sometimes for us, because is it biological? Is it because of some social, community-based factors that is calls for us to look beyond, sex disaggregated, knowing whether these are biological because across the world, in almost all countries, women live longer than men. And this is reflected in our health indicators. So when will you be concerned? When the expectation of life at birth for women is lesser than that of men, then you will be thinking, what is going on? You get it? So that is what I mean when I say biological versus something which is not right. Now, let me show you this. No, I showed you that table. I brought it a little bit more broader and look at this. From another last 15 days for each gender by each quintile class, UMPCE, I have for rural and urban. So if you take the all rural and all urban, more or less same number of men and women got no treatment at all, But if you look at people who got other treatment, more women, you remember Vibhuti ma'am, Sanghamitra ma'am were all talking about trust. Now, 5.3% of men went for other and 7.3% of women went for other treatment. That is made up not in the non-treatment, but in the allopathic treatment shortfall in both places. Now, if everybody gets, if you're all living in the same environment, get exposed to same, insects and mosquitoes and viruses and bacteria. Some diseases will require the same kind of localized trust. Some diseases will require, a different kind, working people will need maybe, and they need a quick cure by taking a paracetamol kind of a thing. We don't know. But the fact that about almost 91% of the men, and for that kind, if it is a local primary health center or something in rural areas, but only 88.7, let's say 89, even that, 1.5% difference. Why? Is a question to ask. Now look at the other way around in urban areas. 19.4 of the men went to allopathy, hardly any difference in the no treatment category for men and women. But more women are accessing. Is it because in urban areas we have urban health post, which is easy, women in the neighborhood, Asha worker comes, Usha comes, everybody, they are able to, the facility is proximate and doesn't involve support from anybody in urban areas because in many places that time is gone. In rural areas, it is still the same. So is it that normative change? Why? These are questions, but you have the data to ask those questions and find those answers. Look at the difference in medical expenditure. No, when we urban and rural across wealth quintiles, when we take overall, we will feel, oh, for men, they are spending far less in rural India than for women. More or less, it is on par. But in urban India, there is a almost, close to 80 rupees difference between men and women in urban areas. But if you look at it, is it the same pattern? Now, you have the average total medical expenditure for treating per ailing person in that particular wealth quintile. Wealth quintile means the total amount of monthly incomes that families have is categorized into 5 equal groups according to certain categories, and that is presented. Our health statistics do give us the basics, but developing indicators, we need to think beyond sex disaggregated data, and we need to ask the question, do we have indicators? For example, we could use the gap in allopathic care across men and women, standardized using male level of utilization or female level to compare. So 90.6 divided by 86.7 divided by 90.6 gives you 0.2 in rural areas, but it gives you minus, meaning in urban areas, minus 0.007 in urban areas, meaning there is a tendency to favor males. The gap in use of allopathic care depicts female advantage in urban area and disadvantage in rural areas. But is it the same across all classes? If we assume that, allopathic care may be, as is seen, the most preferred, because the levels at which we operate are not the same. You look at what I did, I computed it across everywhere. And is it the same across all quintiles? The all level tells you 0.02. No? So if the gap between men and women is to the tune of 2%, but in the lowest quintile, it is to the tune of 3% when compared to men. You get it? Hello? And in reverse, in the lowest quintile, it favors the men. In overall, it favors the women in urban areas. So alternatively, if we had expenditure, we could just use, the average expenditure on women by men for rural India and see how it goes. Clearly, rural India spends more for women than urban India. But is that the same story? Again, I'm giving you the tables. Look at this. I did men by women. And urban India favors women. But when there is enough money in the household, okay, in all lower ages, in all lower quintiles, wealth quintiles, there is a tendency to favor women. Then you need to ask another question. Because when you look at gender indicators, one of the reasons why women have to spend more money is they come later. Doctors will tell you when the disease has progressed, it is more severe and more difficult to treat. Is that the reason why in the lesser quintiles in urban areas, we need to find out. We don't know. But when there is, even when there is in rural India, when there is enough money, there is not a great difference. It comes down to 1. But that is not true in urban India. When they have money, there is preference for treating men. So what it tells you is, but it takes, there is data. But developing these indicators to demonstrate the gendered nature is what we need to start thinking about. It's not enough to demonstrate differences. It has to also show how unfair that would be. If such data is there, it's good for us. If it is not there through existing tables, we shouldn't give it up. we need to go back to the micro data to do analysis and develop these indicators. See, analysis, oftentimes we tend to balk at these micro data analysis because it calls for special skills, and we look askance at the people who have access to the data and treat them as, people who are some form of people who are only doing numbers. But the numbers tell a story. That story needs to be told. If that is not done, then, the disadvantage will remain disadvantage. And that is why we need to make a start to start telling these stories, either directly or through efforts which are systematic. We may not have the skill. Can't we partner with others who have? Thank you.
Thank you, Professor Ramanathan, for such a robust statistical analysis. I want to focus more on the gender indicators, because what we have seen, whether, like, say, let us take an example of Human Development Report 2002 and 2012, where the indicators which are there for human development, current indicators, showed the best performing states in terms of the higher performance is Gujarat, Punjab, Haryana, and Maharashtra, because the indicators were, say, availability of pakka house, safe drinking water, electricity, connectivity with this thing, overall family income, food security, nutrition. But the moment you introduce indicator of declining sex ratio, child sex ratio, suddenly the scenario changes, because that was not included in that. And that's why you would see the states which are extremely, what in Professor Ashish Boshe's language, Devara state, daughter eliminating son preference, son craze for a male child, that kind of a scenario. So I think your ideology, statistics, yes, very important. But at the same time, what sensitivity you have to gender concerns, I think that plays a very important role. Can you give us the example of how you have used your gender sensitive perspective, gender responsive perspective in the statistical analysis?
For instance, I was constantly challenged by how to explain development of indicators, because it's not something that is very simple. What I look at, for instance, I've looked at access to, treatment for diarrhea. Okay, for girl child and boy child. And because the N of cases is very small, it's very easy to have a tendency to put this data together, because then we can compute rates and ratios for treatment for diarrhea. But when you are suspecting that there is a difference by male, female in that community or anywhere, the first thing is to not to merge these two. Because we are very greedy for getting statistically valid rates. But sometimes there are other ways of standardizing and still rendering them comparable. And that is where we need to apply our minds by, I'm giving you this example of, number of children who get diarrhea. Boys get diarrhea in the same house, a girl also gets diarrhea. But then you have to ask the next question. What treatment was given? We ideally say ORS, no? So if every child which got diarrhea is given ORS in the house, boy child, girl child, it's okay. Girl child is given ORS, boy child is taken to primary health. Now there is, you can see the difference, no? So that kind of approach is needed. Then you can always give comparison of the total children. You don't need to standardize it. So you need to think. And if you think you need to look for it, you have to start looking for it. And when you look for it, it's a threading a line between statistical sufficiency and the need to tell a clear story that is valid and is not unacceptable. See, not everything has to have a statistically significant p-value. There are many other indicators. We may not know enough statistics, but there are a lot of people in the world who do. There is nothing wrong in working with all of them. Does it help, Dr. Vibhuti?
Yeah, it does. There are questions, 4 questions for you.
I can't see them.
Yeah. Sasha and Nijhara, can you introduce yourself and ask your question?
Yes, ma'am. I'm Sasha. I'm a public relations consultant for social impact organizations. And while you were explaining how data that comes under, like when you compute it, it comes in minus. If you could re-explain that, it would be great. As we use a lot of data sets that are given by government. However, this is something new that I witnessed today. And if you can just explain us again how the data that was coming in minus 0.007, how to read that as a layperson.
So that is, I simply just put the male rate, the male value proportion minus the female proportion. But what happens when we do that? No, we don't know. See, I'll give you a simple example. This is Sasha.
Yes, ma'am.
Supposing the proportion of people who went to allopathic clinic in that village were only 10% in one place, and another place, men were 10%, women were 8%.
Right.
Right?
Yes.
Now, in another place, it is 90% and 81%.
Okay.
There 2% difference is there in first village. In this place also it is only 2%. But here 89% people have gone for treatment. In the other place only 10% have gone. How do I get that into my indicator?
Right.
So I need to capture that. That is why I put the male level into the denominator for M minus F divided by M. It could have been anything. M plus F also I could have done. But in a way, what we call this is known as norming, norming to the level. So that we really cannot compare a 2% difference at 10%. Okay, which is huge. Okay, it is 2 out of 10.
Yes.
It is 20% difference when compared to 2% divided by 90. 2 divided by 90 is not the same. No?
Yes.
You see, so like somehow they will get there when it is 90% already. You don't quibble. But if people are going for treatment 10% and 8%, you need to really think. So you have to bring that level into it. That is why I've put it like that. You get it. But so if it is M by F, but the women are getting more allopathic. Then M minus F will be negative. So it will favor the women. If M is bigger than F, then it will be positive. It will favor the men. Now you got it? It is the gap in men and women standardized by the level.
Okay,
Got it?
Yes, ma'am. Thank you.
Hello? There is one hand, but I can't understand from...
Ma'am, there's one question from Equilin Johnji. Equilin John. Yeah.
Hi, ma'am. My name is Aquilin John. I'm a student of psychology. My question was that this medical expenditure skew towards women, how much of that is explained? You said that part of that is explained by how long they wait to seek medical treatment, right? It's part of that also explained by things like fertility treatment and contraception and prenatal procedures, etc.
No. It doesn't, because the National Sample Survey Organization and none of this actually collects that kind of data at all. This is for this particular data is ailments during the past 15 days and the treatment for that. I took a very simple thing which I didn't take hospitalization things, and the NSSO is very careful with that. It doesn't include, for comparison purposes, maternity care. So when I'm comparing, I'm really comparing comparables. Hello, does it? Madam, I
Yes,
can't
ma'am.
see.
Understood.
But what about the very capital intensive treatment? If the metadata says that we have 35% of Indian women have carcinoma, it's a very expensive treatment. Every third Indian woman, if she has a carcinoma, then it must be really very expensive, no?
It will be very expensive.
Even if it is subsidized by the trust fund and all, it would be expensive. People are selling land, they're selling home, they are selling gold for the treatment of carcinoma patients.
Yes, they are. And even breast cancer families make a systematic effort, particularly, I mean, you know, this olden days, imagining neglecting women and all that, to a large extent is not, because NSSO, how much ever I keep, wanting to see gender difference, the things which I saw in the 66th round is not there in the 71st round. Then in 2018, the difference was getting narrower and narrower. And I was getting gap elsewhere. Like I started then looking for source of funding, not the nature of the ailment or the total amount of money spent, but source of funding. And you found that asset sale only happened far more frequently for men than for women, because it becomes very, so the story for gender is it okay to say a word in Hindi?
Yeah.
Then I will try and translate. It's like digging and digging and digging, khudai or khudai कि कुछ तो पॉटरी मिल जाए, कि पुराने जमाने का कुछ कहानी मिल जाए. It's a archaeological expedition in data. You have to dig and search, and it's there, but it's not very superficial and easy to locate. And so we are not overtly biased, but for whom the bell tolls, you will understand when you see where like सब कुछ बेच के, yes Vibhuti, cancer के लिए करेंगे in certain context, but not everywhere. Because also we've conditioned women to say, हाँ सब कुछ चलता है. And the reason why sometimes it is costly is severity at presentation. Time after time, medical anthropological literature indicates that. Does it help? I can't see that, madam. Dr. John.
Hello. She had asked this question yesterday. I asked her to wait till today's session. Yeah. Hello. Yeah. Hello. Yeah.
Is that okay?
Yeah. So, Dr. Shruti Sharma, can you ask your question? Hello.
Hello, good evening, ma'am. Once again, thank you. Dr. Mala, I wanted to understand, first of all, thank you for, highlighting very valid points in your talk. One, definitely about, interpreting the data in a right manner, and also, the highlight about asking the right question to, dig that data out. So thank you very much for highlighting those points. And I was very interested to understand, when we are talking about open data sources in government, are there any authentic sources, where disease specific data can be extrapolated at a national level? For instance, if I want to understand hysterectomy or, a diabetic data set for my country, it could be on various other, indicators from a gender perspective or a city wise. So what should be those sources to rely upon?
No, actually, you know, it's not that we don't have data sources. See, I would not take the NFHS data because its sample size comes from a very restricted, reproductive ages women and their partners and their families, So the prevalence rates of diabetes that you get there are different from what we get from the National Sample Survey Organization's data on diabetes.
Now, what's the difference in the household survey? How many households per state and union territory? They have NSS.
NSSO does have a
NSSO around 1.2 to 1.5 lakh. And number
and
of
it's close to now 5 lakh plus population.
Yeah.
Yeah. So, and the major handicap is that we have 2,300 odd mortality or deaths also in that most recent data set. That is a data set that you can use to look at characteristics. The handicap is for public policy, but not for clinical decision making. For the simple reason, Dr. Shruti Sharma, that no doctor will accept self-reported diabetic status as a means of final decision making, even though we can be arguing here that nobody is going to say I have diabetes when they actually don't.
Yeah.
Does it help?
Noted, ma'am. Noted. Yes, ma'am. Thank you for your answer, ma'am.
Yeah. So now, Dr. Amruta Girish, will you ask your question and introduce yourself?
Yeah. Good evening, ma'am. I'm a development professional. My question was, what are your thoughts on the health indicators included in Niti Aayog's multidimensional poverty index and your thoughts on the effectiveness of the index itself as a reflection of the country's poverty level?
See, the multidimensional poverty index uses equal weights very much like the HDI. And see, we in India operate at so many levels. No? See, in different states, we are like as if we are on different continents. No, in some parts we can say yes. No, Vibhuti madam pointed out in 20 states we've already reached replacement level fertility. But there are other places. So when we take multidimensional poverty like indicators, what is it that we want to put into it to capture it? And should we be giving equal weights for all the indicators? Are two questions. If we are okay with, equal importance for all indicators, then we live with it because it's a simple additive indicator. But our capability of developing indicators has gone way beyond all a simple min-max estimation, and we should be doing alternatives as well. And the debate will go on. For other persons, for the Niti Aayog, it's possibly ease of use and ease of understanding.
Yeah.
Then people will argue, is it comprehensive? Is it consistent? But, we can keep arguing from here to next 3 years or till the next value comes out. But this value has been accepted and we have to live with it for now. Vibhuti Patel ma'am can also add her comments to this.
Yeah, I think it is basically when it first came, when the Human Development Index came, where that and I think the both economists, Mahbubul Haq from Pakistan and Amartya Kumar Sen from India, where the major consideration was that of a life expectancy, means health indicators, educational indicators, and the employment indicators, which would also feed into quality of life. When then the gender economists, they came up with the Gender Development Index for focusing on the gap, which I think Dr. Mala explained to us, that the gap in education, gap in life expectancy, gap in employment, and gap in the overall quality of income and all. But after that, when the understanding came that even freedom, dignity, choice, liberty, decision-making power, representation, they are also very important. Then the new indicator came was a GEM, gender empowerment measure. So you also, it is not only developmental investment of health, education, and employment, but whether you have a voice within your family decision making in the community, in the political structures, at the workplace. So I think most important thing that what is the theoretical perspective that you follow that contributes to multidimensional poverty. Now, multidimensional poverty focuses on what type of housing you have. With time poverty, they talk about that, whether you have a time for yourself, because we talk about the time, personal time, or care time, care work, which the women do, even both men and women both do. And the MOSPI has for the first time given data, time utilization data in 2020, which talks about Indian man spend on an average 99 minutes for care work, while Indian women spend 299 minutes for care work. So what is the, how much time it goes to care work? Because your time and energy in care work also reflects to work participation. And currently we are fighting with the mind-boggling issue that the Indian Niti Aayog has is only 19% women are part of the workforce. So I think for the planning and both the identification of practical gender needs, which where immediate intervention is required, and the strategic gender needs, where you long-term developmental and the nation building cause for this multidimensional poverty is very important. And why it becomes important in the post-corona context, because we saw nearly 30 million Indian migrant population had to face tremendous human misery. Earlier, we always treated migrant workers as a sponge, as a burden on the urban economy, but we all realized what happened during the pandemic. So urban housing becomes a very important. Can you leave it to the market, or the state has to intervene? Why only in Kerala we have a workers' hostel? We don't have it in other places. So when you have a multidimensional poverty, which takes care of the safety, then the ease of business, ease of travel, the condition of what the self-employed people, own account workers, the challenges they face, because vendors, we had to come up with a special program in Atmanirbhar Bharat Youth, not just for the vendors, because in one city you would have nearly 2 lakh vendors because they are their own account workers. So this, when you have all these multidimensional aspects in your development indicator, then it makes the targeted intervention, because that's what the government now, everywhere they want to want targeted information. Even when you prepare the report of the state, I was involved in the Maharashtra Human Development Report. What they were giving us is a 365 blocks are there in the state. So in Excel sheet, they give you data of all 365 blocks. So there are multi-dimensional, because how many schools are required, how many health centers are required, midday meal program if you have, how do you target, which should be focused on the ICDS center or in the school. If their schools are, children are not so much in the school, how will you attract them, and how will you see to it that the child nutrition is provided? So when you have multidimensional program indicators, then intervention becomes very important, very effective at a micro level. And also, I think because at a subnational level also, it feeds into your budget, okay? And how many budgets need to be converged, like whether if you have a, say, in a tribal area, and you are talking about child's education, then you will go through the TSP budget, you will go to the food Ministry of Food Supply and PDS budget, and you will also go to the education budget if the program midday meal is operationalized in the education. So going into the minutest details of each area and in a multidimensional level. So you may have, say, urban people, they may have a food security if you say talk about the carbohydrate and protein. But if there are no micronutrients, so now the focus is also that it's not only just rice and wheat, but also micronutrients are required. So multidimensional poverty captures all these aspects, which are very important for your day-to-day survival, and also for the city planning even when you are talking about the smart city program, whether is because currently the major deterring factor is mobility. So far as women is concerned, you saw what happened to Nirbhaya. Okay, at 9:30, a physiotherapist tried to go home and she gets raped. So this is very important, that how many people, women are working, how many are working on the shift, they have a shift duty, what kind of the nature of labor processes they undergo. And accordingly, you make the intervention and provide the infrastructure and facilities. So with all this, it becomes far more effective for the implementation of policies, and very, very evidence-based implementation of policies you can do. First formulation as well as implement.
Actually, it's not only us gender and health experts. I find, especially from an urban planning perspective, a lot of architects are bringing in gendered spaces for women in urban areas. So that is a very strong resource because they have out of the box ideas about doing things. And I sometimes keep thinking that why didn't we think of it? But they do. They come up with, and then you look at how the space changes. Like in my city now, we used to have a lane which was not for traffic. We could get chai and this small, like people in Mumbai can drink tea anywhere. No? We can stand outside. For a lot of in about 10, 12 years ago, we couldn't stand outside and drink tea. It was not done for women. So now we had that notion that it is possible. So now it is caught on. You have every chai shop, there are men and women drinking tea outside in that paper cup. So that starting of that Manaviyam, where we had this lane which was no traffic and you could have food kiosks, mostly chai and some small thing to eat. But, this kind of fighting and arguing for spaces, and how many such spaces exist?
Gardens, playgrounds for the children.
Which are like women friendly. So you ask questions about toilets. It's in public spaces, no, which are women convenient. It's not just putting a booth. Is it cleaned frequently?
And why the differential? In Bombay, Sulabh Sauchalaya was not charging anything from men, but for women, they were charged 5 rupees. No? So that also became an issue in the right to pee campaign.
And it's not merely a right to pee. The provisioning for that right to pee, it cannot be equal. Now, here is that biology I was talking about. Because of the cultural requirements of the clothing that women wear and the possibility that on an average, a woman could be menstruating. The time that she takes in the facility is a little bit more than the time taken. So if men and women need to pee at the same rate, the time that women need in the loo is more, then the number of loo toilets for women has to be more. You can't have equal toilets for men and women.
And the transgender people, they would separate toilet because they don't want to use gents' toilet. And women, if they use women's toilet, women get scared. So they say, we want our own toilet. So Chhattisgarh is the one state which has provided the public toilets for transgender persons.
But these are the kind of things where we need to start discussing.
Yeah. Because RTI, if our statistics show that majority of Indian women have reproductive tract infection, then we need to come up that then this kind of social infrastructural facilities become very important. So multidimensional indicators, they pick up all these important lived, they are based on the lived experiences of the population and the specific needs of the population. Person with disability would have a very different needs, no, in terms of ramp and in terms of disabled friendly toilets. That is also very important. Yeah.
Have I answered?
Yeah. Fine. Any more questions or any more Experience sharing.
Anushri, I guess Anushri wants to ask a question.
Yeah, please go ahead.
Anushri ji.
Thank you, Dr. Mala, for that wonderful presentation on health statistics and health indicators. Having said that, I'm somebody who's been at least from past 6 to 7 years working on NSS data from the unit level, and trying to probably make sense of certain variables or indicators. Variables. So having said this, my question to you is, if you look at the NSSO data, especially on the indicators on health expenditure, right? At the disaggregate level, where they try to capture a rich data in terms of how much they spend on medicines, could be on surgery, etc., etc. Right? 50% of the data goes on missing value, right? And which is largely, at least, if not 50%, at least 10% of the individual cases has a missing variables or not answered. Sometimes it may be given free of cost. Partially, it may be they might have paid, but still it goes as a missing variable. Nothing is being recorded, right? Having said that, the latest round probably overcomes by making it a zero and trying to calculate the average expenditure, right? So in that process, somebody who knows these nitty-gritties of manipulation of data probably gets the right answer, probably the answer that the report has produced, right? While if you really don't know how that is being produced, and you end up probably extracting the data from the unit level, you may end up with a different answer for the same variable, right? Which brings to the important question: with the same data, you have multiple kind of interpretations that you can come up with, right? So if such data sets are used for public policy, what would be the validity if you have multiple interpretation? Probably I would want to hear from you.
Anushri?
Yes.
There is a way of verifying in NSSO data. We go and check the base report. Okay. First, no one would ever take up that analysis without verifying the base report. Okay. That base N of cases, we verify very systematically. You get it? And if it doesn't match, we have to give a reason why. In fact, when NSSO imputes the mean value for the missing values, it becomes a bit of a problem because you wouldn't know where it imputed and where the value was the mean. Do you get it?
Yes. I mean, I was somewhere relating to...
Anushri, can I finish?
Yes, ma'am.
I'm not comfortable with the word manipulating the data.
Okay. I mean, my apologies. I wanted to say impute, but then...
I wanted to point out that it is they impute, different people impute for different purposes. So the rationale for why someone does something, how you impute the missing values, and how systematically you report it is what an ethical analyst should do. Give the flowchart of how your N of cases came up.
Mm-hmm.
Let anyone else repeat that, replicate it, because the data set is the same.
Mm-hmm.
You get it? So that is how we validate a data set. If I can take the same script and generate the same N of cases, no? If you tell me exactly what you imputed, where you imputed using a flowchart, that is a clean way to do it. And that is why the American Statistical Association's advisory, which was issued later on, there was a hue and cry, was about how outliers are dealt with and how we deal with missing values. It is a statistician or analyst's duty to report on that. It is an ethical requirement to report on. not manipulate.
Sorry,
And-
my apologies for
No,
using
but
the
I'll
wrong
finish the
terminology.
thing.
Yes.
Different NSSO rounds, no? People need to be very careful in reading because, see, very often when we publish papers from NSSO, we get stuck with 3,000 word publications, right? Things like this, in which we, in some places, when you have, I think in the 66th round, we had the proportion of money for the total treatment, which came from assets, from savings, from family and friends, and the fourth category. You could get it for different aspects also, and you could merge it together. But in the subsequent round, suddenly there was only one number. You couldn't merge it. So when we did that analysis, what all of us had to do was take only one single hospitalization. We had to drop multiple hospitalizations because the comparison was not possible. So when we report, we took single hospitalizations because each round had a little tweak. You get it? So that care has to be exercised in reporting also. Sometimes researchers, how do I say it? Everybody knows that. We think everybody knows that, but there is a lot of people who actually don't, and we don't realize that. So certain rounds, people would have used single hospitalization only because the data set in the earlier rounds would allow us to deal with multiple hospitalizations for the same person and multiple hospitalizations across different persons in the household. The recent round is, I haven't checked it, but till the previous round, 71st round was very difficult to separate. So we did analysis with one hospitalization. It was about 81% of the total hospitalization cases, but still you could tell a majoritarian story. But if there were repeat hospitalizations, we missed it. And the expenditure for that would have been phenomenal. Those would have been the real outliers. Those would have been the real households which needed attention because out-of-pocket expenditure for that would have been very high. What is the gendered nature of that? That is another story, but those are stories we couldn't tell because there were some of us who were, trying to tell at least a straightforward story on multimorbidity for women. At least with one-time hospitalization, why is it the average expenditure is lesser for women? Then I standardized it by number of days. It was still less for women. Number of days of hospitalization. So, you keep doing things to figure out a way to tell a clean story to be published. And in that, sometimes some stories get suppressed. That is, it is the researchers or authors' duty to state exactly what are the assumptions that they made and how they use that data set. Because if I have eliminated 19% of the hospitalizations, it behooves me to say that explicitly. Some people may have just not given. See, in earlier publications, journals did not insist on the flowchart. Now journals insist. So it makes your life, if you read papers from 2001, 21, after all the hangama about, what is it? Vibhuti, there's a word now, wo jo publish karne ke pehle, preprint. Preprint issues came up. Journals are very strict about giving the flowchart. So it will get better.
Thank you, ma'am, for that.
Does it help?
Yes, still my apologies for using a wrong terminologies.
It's not that. Oftentimes, Anushri, I'm not offended at all. Let me be very upfront. I've been a statistician where we've been called statistics are lies, this kind of lies, that kind of lies, and a lot of bad words. It has never offended me because अपना कलाम है यार, उसको छोड़ के कहाँ जाएंगे? कोई कुछ भी बोले, वो मेरा कलाम है ना? तो आप कुछ भी बोलेंगे, मुझे फर्क नहीं पड़ता. So I'm not offended, but I was just trying to say that बहुत सारे लोग, they work very hard to generate data, to generate evidence. And I didn't want, just as, using epithets like quack for alternative treatment options is not acceptable. Similarly, alluding to a misdemeanor is also not a nice way. That's what I wanted to point out, that it's not a
Sure, ma'am.
That's all.
Ma'am, one more question, if I may. I had asked this question in the previous session yesterday on healthcare utilization, where women have higher relatively higher healthcare utilization compared to men. I mean, both in 71st and the 75th round, the recent round, which you also kind of pointed out, at least for the urban, areas. So having said this, this is these results are somewhere not in, it is not in line with.
Have you seen where?
Pardon?
Have you seen where?
Urban areas.
No. I meant, where did they go for healthcare? I did that.
Yes.
I actually managed to get figures into it because it is impossible to test it statistically. But I managed to draw bar charts to show male-female variation by rural-urban for diabetes. And while healthcare utilization is high, they go to the for treatment for even stroke. When I did analysis, they went to primary health center.
Yes.
And they did not go to tertiary care institutions, either in the private or public. And I had done this separately for private and public, and noticed that tertiary care government hospitals, more men, and tertiary care private hospitals, more men. PHCs, more women. Just check. You'll realize this difference. So that's what I meant when I said, look, Udai. Anushri, does it help?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
And I think it can also be because of the health post in the community, no? That also makes healthcare facilities more accessible to women. And the new programs of Janni Suraksha Yojana and all. But I think maternity is left aside. So I think at least having health post in the community and ASHA workers and Anganwadi workers as a facilitator may also be the responsible factor.
Yeah, but Vibhuti, that works for common cold and all that. But stroke ke liye?
Yeah, that's
I did analysis for stroke and we were surprised. Rehabilitation in stroke, it is rehabilitative care. When you look at amount rehabilitation, women.
Yeah, okay.
That's what I meant. Now it is like an expedition, searching. Yeah. Anushri, does it help? Keep trying,
Yes.
yeah. There are so many stories to be told. I'm glad you're doing stuff like that.
Thank you, ma'am. Probably I'll get in touch with you for much more guidance.
Yeah. Dr. Mala, last question. How do you see the role of triangulation? How can qualitative data bring the nuanced understanding of health statistics and indicators? Your take on it.
Some of the best, searches come from qualitative data, which tells us that it is there. If we forget, if we don't dwell, see, statistics, is not like an absolute value. It is a method of showing things in a standardized way. You should not get, stuck on, I need a significant P. If you're not stuck on that, you need to tell a valid story. That is different. That is very different. A statistically valid story is very different from extracting a significant P from data. And therefore, qualitative research, any forms of, anthropological expeditions, instincts which emerge, this analysis which I talked to you about, diarrheal care and differences, came because of a PhD student's work in the field, where slowly he began to realize that girls are getting ORS, but the N of cases is too less. So it was his, how do you say, sitting outside, chatting with mothers and slowly finding out these little stories for which then we go and search in the data set, which makes a difference. So it's quantitative data can ask you to, go back to search for reasons in qualitative, setting up a formative research exercise to finding out why. No, it can be a two-way process. It's never, there is no such thing as, good research. I mean, there's only good research and bad research. You can't keep saying, I will do a quantitative study on Palana thing, or I will do a qualitative study on Palana thing. No. If you ask the right question, do the right thing to find the answer.
I think with that, we conclude that you ask a right question to get the right answer. I think we had a very, very lively session. Professor Sanghamitra Acharya, she gave us a nuanced understanding of differential gender impact on the gender and the vulnerability, gendered vulnerabilities of women and men and gender minorities in a different situation. She talked about the women as a health seekers, women as their reproductive health needs, women health workers, their and their predicament, learnings of African experience of Ebola, and how the not having a correct perspective resulted in massive maternal and child death because of the state policies were not responding to what was happening, and there were no such ground level data that was available. And she also gave us example of a global pandemic and why it is important to learn from the history of medicine, history of pandemic and epidemics, so that mistakes that happened in the past are not repeated in future. And I think Professor Mala Ramanathan, she gave us a very robust statistical analysis. She also told us, oriented us in the various data sources, right from Census of India, SRS, MHA, NSS, MOSPI's work, NFHS, HMIS, and also answered the question. I am really, once again, I congratulate the participants for asking such sharp questions, and also keeping your engagement in such a demanding, serious sessions of for nearly more than 2.5 hours. Thank you very much.
Thank you.
Thank you, Professor Mangal.
Thank you so much, ma'am.
Good night.
So as we have come to the end of day 2 of Healthcare and Gender Equity, an online international monsoon school program, a 4-day immersive online hands-on certificate training course, I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Gender Impact Studies Center, New Delhi. We are grateful to our experts for the day 2 session, Professor Sanghamitra Acharya, Dr. Mala Ramanathan, and Professor Vibhuti Patel for taking out their valuable time and giving us an opportunity to learn from this online certificate program. We thank all our participants who have raised pertinent questions and actively participated in today's deliberation. We look forward to welcoming you tomorrow at 6 p.m. for the 3rd day of the certification course. We are grateful if you are watching us later on YouTube or listening to us on our various podcasts or reading our publications. We hope you continue to join in future to improve web policy talk and web policy learning. I wish you all a very good day. Thank you.
Yeah. And from Roshni Babu, happy Onam to Dr. Mala Ramanathan. And I think you're happy Onam. Very
Thank you.
Yes. Nice.
The interruption was somebody giving me payasam.
Yeah. Very good. Enjoy your payasam. You have done a good job.
Thanks.
Yeah. We can't hear you, Dr. Sanghamitra. Please go.
Thank you.
Okay, thank you. It was really a very lively session. I also feel
Bye.
energized. Yes, it gave us that.